So hello everyone, my name is Sarah Isinga and I'm the manager of the patient programs, research and advocacy here at Lymphoma Canada. And I'm pleased to welcome all of you to today's conference session on chronic lymphocytic leukemia and small lymphocytic lymphoma. We appreciate those that are able to attend live today to learn more about the disease-specific biology and diagnosis of this lymphoma subtype. This presentation will highlight novel research and treatment options that are accessible to lymphoma patients across Canada. And now, before I introduce today's speaker, I'd like to provide some guidance on the Zoom software for this session. This virtual software does not allow you to share your video or your microphone. If you have a question, please save it for the CLL Q&A session following this presentation. And this is where you can ask your questions to the presenter live. I would now like to introduce and welcome our speaker, Dr. Yin Yang. Dr. Yang is a hematologist and researcher at Cancer Care Manitoba and has a clinical practice in lymphoma, including chronic lymphocytic leukemia and general hematology. She attended medical school at McMaster University before returning to University of Manitoba to complete her internal medicine and hematology training. Before medical school, she completed her PhD at the University of Toronto, and the focus of her doctoral research was on cancer-driving genes in acute leukemia. Her current major area of focus is on chronic lymphocytic leukemia. We thank you very much for joining us today, Dr. Yang, and you can go ahead with your presentation.
Thank you very much, Sarah. Yes, and thank you for this opportunity and welcome everyone. I'm very pleased to discuss with you today and share my thoughts on chronic lymphocytic leukemia and small lymphocytic lymphoma. These are my disclosures. So let's start off with what is the difference between CLL and SLL? So CLL stands for chronic lymphocytic leukemia, and that's when when cancer cells are detected in the blood. And often that is how it's picked up. When that is found, then your doctor will request special blood tests, which will make the formal diagnosis of CLL. Small lymphocytic lymphoma is when you or your family doctor detects enlarged glands, and these are called lymph nodes. And when we biopsy the gland, we see that it is filled with cancer cells, and that is called small lymphocytic lymphoma. Clinically, CLL and SLL are considered the same entity. One presents in the blood, one presents in the gland. But they're both of the same type of non-Hodgkin's lymphoma, and they're both treated the same. We think that CLL and SLL came from a precancerous state called monoclonal B-cell lymphocytosis. This is very common, especially as we age. It's a condition where there is a small amount of CLL-like blood cells that's found in the blood, but it is in such a small amount that it doesn't really affect a person. And for the most part, when you have this, it will stay in that very small amount and doesn't cause any problems. However, about 1 to 2% of patients per year, that clone can grow and can turn into CLL or SLL requiring treatment. The distribution of these entities is mostly CLL, 70%, SLL is less common, it's about 15%, and about other 15% is MBL. So another way to look at it is to break it down into a table. So as MBL is precancerous, you would expect very low blood involvement when we test the blood, and you would not expect any glands to be enlarged. SLL, on the other hand, because it's a lymphoma, which is a cancer of the glands, you would automatically expect the glands to be enlarged, but no blood involvement or very little blood involvement. CLL, because it's leukemia, would have high blood involvement and may or may not have glands. SLL and CLL are the most common leukemias, lymphomas in North America. It is very chronic in nature in the sense that it grows very slowly over time. And we sometimes use the word indolent to describe that process. It is more common in men than in women. Another important thing to note about CLL and SLL is that the average age of a patient that's being diagnosed is 72, which means that about 90% of patients that come to our clinic will have at least one, if not more, other medical conditions, perhaps highlighting that this is an older population, maybe with some comorbidities or co-medical conditions. So the most common way that a patient gets diagnosed with CLL and referred to the clinic is when someone undergoes regular or routine blood tests with their family doctor. And when they do that blood test, they notice that a type of white cells called lymphocytes are increased in the blood. So I have shown you here what's called a blood film. This is when someone goes for a regular blood test and their blood is actually spread across a glass slide. And then you look under the microscope at the glass slide to see the blood cells that we make. So we make 3 types of blood cells in our body. And these are made in what's called the bone marrow and gets released into the blood. The 3 types of blood cells are 1, red cells, or another word, hemoglobin, because it carries oxygen in our body. Platelets are a type of blood cells that makes blood clots and prevents us from bleeding, for instance, when we cut ourselves. Lymphocytes, as I've highlighted here, are a type of white cells, and they are purple in hue and color. When the doctor sees that the lymphocytes are increased, they will do a special blood test called flow cytometry. And what it will show is that these lymphocytes are clones of each other, and that on their surface, they're expressing a very specific CLL cancer markers. So when you have these 2 components together, it makes a diagnosis of CLL. CLL and SLL can involve the glands. So I have shown you some pictures of what it would look like. On the right is someone with a gland that is enlarged in the armpit. On the left, on the right is someone who has an enlarged spleen. It may be a little bit hard to appreciate that, so I've included a cartoon diagram of where the spleen would be located. Normally, the spleen is on the left side of the belly, and it is tucked underneath the rib cage and can't really be felt. But when the spleen is enlarged, and it can in CLL and SLL, because the spleen is a lymph organ, so when it gets enlarged, it will descend below the rib cage and can be felt on exam. So why would the glands and the spleen be enlarged? Well, this is where the cancer cells sit, and they grow and they divide and they expand there. So therefore, the gland or the spleen gets enlarged. When someone gets diagnosed with CLL, we also do staging. And the particular type of staging we do for CLL is called Rai Staging. There's also a Bene staging, but locally in our institution, we use Rai Staging. It describes the natural history of CLL. So in stage 0, the very first stage, you only notice the increased CLL cells in the blood. In stage 1 is when the glands are enlarged or the lymph nodes can be felt on exam with your doctor. Stage 2 is when the spleen can be felt. And stage 1 and 2 together is intermediate risk. Those with high risk, So stage 3 or 4 are when other blood counts are starting to drop. And that's your hemoglobin and that's your platelets. And they drop because the CLL in the bone marrow is growing and expanding, compromising the other blood counts. In our clinic, the majority of the patients, about 85%, come to us in Rai stage 0 or 1. And that's because the routine blood testing that picks up these cases. When someone is diagnosed with SLL, because there's very little involvement in the blood, we have to use a different staging system. And this is what's called the modified Ann Arbor staging system, where we describe the distribution of the glands. So if someone has one gland, that's stage 1. Stage 2 is when you have 2 glands in separate areas. Stage 3 is when you have glands above and below the diaphragm, and the diaphragm is our breathing muscle. Stage 4 is when the cancer cells have expanded beyond the gland system. So for instance, into the liver or the bowels or the lungs or the bone marrow as examples. So over time, what do we expect with CLL and SLL? We expect 2 main things to happen. One is that these cancer cells will grow and expand. Remember, they grow and expand at a very slow rate, but they can ultimately go to the bone marrow, the factory that makes our blood cells, and causes low hemoglobin or low red cells. As a result, someone can feel tired or breathless when they're doing activities because there's not enough oxygen being delivered by these cells. The other thing is low platelets. And because platelets are prevent bleeding, you may notice extra bruising that you haven't noticed before, or there could be a bleeding episode as well. The other thing we notice with CLL and SLL is that there's a compromised immune defense system. So what we see is that other cancers other than CLL and SLL can come through, and we can also see increased risk of infections. And these infections can be bacterial, can be viruses, and can be fungal infections. I will talk a little bit about that in a few slides. The clinical course for CLL and SLL is actually quite variable. We estimate about 50 to 70% of patients in their lifetime will require treatment. Meanwhile, that means 30 to 50% of patients will actually never require treatment in their lifetime. And when someone gets referred to our clinic, because they get referred in such early stage, we actually cannot tell at that time if someone will require treatment or not, and therefore we follow everyone closely just in case. We generally look at CLL and SLL as incurative cancers, but it is very treatable with many treatment options in which I will go into much details later on. So this is an example of someone who has received treatment to give you an idea what the clinical course could look like. So the green lines are the cancer cells, the lymphocytes, and the red lines are the hemoglobin or red cells. You can see at the start, the lymphocytes are increasing, but it doesn't do anything. But over time, few years, you can see that the red cells are starting to drop as the cancer cells increase. So now it is time to treat. Treatment gets rid of the lymphocytes. You can see the green lines dramatically reduce, and then the hemoglobin recovers back to baseline. This gets monitored over time, and then some years later, you can see that the lymphocytes are rising again, and the hemoglobin is starting to drop again, so likely needing treatment in the near future. There comes a time where many patients, especially at the first diagnosis, is such early disease that they do not require treatment. And they enter a period of what's called active observation. Some people call it watch and wait, but I prefer the word active observation because we are closely following. What is the philosophy? Why do we do this? Why do we not treat everybody at the time of diagnosis? I get this question a lot through my clinic. Well, the answer is in three folds. First of all, we do know that many patients are diagnosed with early disease and can live a really long time without ever requiring treatment. That's the 30 to 50%. So in those patients, the disease does not affect them. So they could live symptom-free and treatment-free for their entire lives. So they're really essentially spared of any treatment. We also have many studies that show that if we treat early or we treat aggressive, it actually does not mean that you will end up living longer. And this is primarily because CLL is not curative. So even if you got rid of it earlier on, eventually in time, it will come back and may require treatment. And then lastly, the reason is there are side effects of treatments. So if we have a population of patients who never required treatment, you've essentially spared that population from these side effects. So for these reasons, we do active observation rather than treat right at the time of diagnosis. But during this period, you should expect that you're getting followed up closely with your cancer doctor. This is in terms of clinic visits, so they can do a physical exam. You will have blood work to go along with that visit to monitor. And at these visits, we're also assessing for other signs and symptoms of CLL that is not necessarily directly related to how much cancer cells you have in the body. We're looking at issues such as infections. We're looking at screening for other cancers and ways to boost your immunity. So this is the part where you can look to see, what can I do to help myself? First of all, I would recommend to keep yourself as healthy as possible. A healthy weight and healthy diet, and don't smoke and limit the alcohol. Just in case you need to get treatment in the future, you're in the best shape that you can be, and also reduces your other risk factors for other medical conditions that may limit your treatment options. Some studies show that taking vitamin D can boost your immunity in CLL, and it is a very natural vitamin that we only get through sun, and in Canada we don't get enough sun. So in our clinic, we routinely recommend vitamin D 2,000 units a day, as long as you don't have any issues with that, particularly kidney disease. Second, cancers. We have shown that the risk of developing additional cancer, so not CLL or SLL, but other cancers in your lifetime, is increased twofold if you have CLL. So we recommend everyone to follow their local guidelines for screening for other cancers. But be mindful that skin cancer is just as important. In fact, skin cancer risk is increased 5 times in someone who has CLL or SLL. These are pictures of examples of what some of the skin cancers that we see in the clinic, and we routinely refer to a dermatologist, and we recommend, healthy advice such as no sunbathing and sunscreen. When it comes to infections, we see that quite often, and that comes down to the fact that the immunity or the immune barrier is compromised in people with CLL. So to help yourself, we recommend getting up to date with immunizations. This does not only include COVID, immunizations, but also influenza and the pneumonia vaccine. Some patients who have recurrent infections, we may find that they have low antibody levels in their blood, and these are called natural immunoglobulins. So if they have low levels of antibodies plus frequent infections, your doctor may start talking to you about replacing those immunoglobulins with something called intravenous IV through the veins immunoglobulin replacement, or subcutaneous through the stomach muscle, stomach skin. We inject the immunoglobulins to replace, much like insulin. Typically, we see this when someone's CLL is progressing and likely to require treatment, or if someone's had prior treatment, they may develop this. So if you and your doctor decide that treatment is indicated or is coming up, what should you expect to happen in that phase? So in this section, we will talk about when do we treat and what is the pre-treatment testing. So when do we treat? There are some situations that help guide us as to when we think the burden of the CLL is high enough that is actually impacting you or impacting how you feel, or you're impacting your blood counts to the point where now treatment is needed to reduce that burden. So one of the things is lymphocyte count doubling time. We look at how quickly the cancer cells in the blood, if you have the CLL phenotype, how quickly that lymphocyte count is going up. If it's doubling every 6 months or less, that's a sign that there's increased burden. If you have glands, then we look at how quickly these glands are growing. We look at your other blood counts, such as your red cells or platelets, to see if they're dropping as a result of the CLL expanding. We look at if you're systemically or constitutionally unwell from this. So this is pain from enlarging glands or spleen, or you have drenching night sweats or weight loss of greater than 10%. That's a sign that is starting to take a toll on you. And lastly, we look to see if your own body has triggered the breakdown of its own red cells or own platelets. And these are immune signs coming from your CLL, and that alone could also be indication to treat your disease. When we start talking about treatment, we have to personalize it. There are many elements that we need to collect before a treatment decision or treatment drug or plan is in place. And what we really want to do is find the right treatment that's going to give you maximum disease control, so the disease goes into remission with the least amount of side effects. So our primary goals of treatment is to get as longest term of remission as possible, while preserving your quality of life and regaining your function with minimal side effects. So we look at both patient factors when we're making decisions about treatment, and we're looking at disease factors. So some examples of patient factors is looking at how functional you are at home prior to getting unwell. So are you someone who's independent, or are you someone who gets a lot of help or needs a lot of help with your daily activities? We do look at age, although that is not always reflective of the functionality of a person. We look at the medical conditions you have. Do you have a heart condition? Do you have kidney disease? What are your other medications as potential drug interactions? And we talk to you, we have that conversation with you as to what you would like to get out of this. Do you want the deepest remission, or do you just want to feel better? And that also plays into how what kind of treatment you would like. Something that's continuous, or something that is fixed term for a few months, and um, and those are the type of conversations you have with your cancer doctor. When we look at the disease-specific features, this gives us a guide as to where we are in terms of the features of your cancer cells to help us shift our path into one direction or the next. And I will show you many examples of this. We also would look at whether this is your first time treatment, so you've never had treatment before, or have you had treatment and now this is disease that's coming back. So this is what we call relapsed setting. And that also plays a role into what treatments we think would be best for you. So let's go into what are some of these genetic features. And I will spend the next few slides going into very much details. And I recognize this may be overwhelming for some of you, and that's okay. I hope that these slides will introduce the concept and make it more familiar when you have these conversations with your cancer doctor. I want to emphasize that these are not inherited mutations. You did not get them from your parents, and you did not give them to your children. These are genetic changes that are happening within your cancer cells to give it a certain feature, and that's what we're trying to establish here. So in the order of most important to least important, I have listed the three main categories. First is the mutation in a gene called P53. Then is the mutation in a gene called heavy chain immunoglobulins. And lastly is with chromosome changes. So let's go into these in more detail. So what is P53? P53 is actually a really important gatekeeper to keep cancer cells out. The gene itself is located on chromosome 17. So we have 23 chromosomes in each of our cells, and they're paired. That's how we were giving these, half from mom, half from dad. On chromosome 17, there's a tiny spot where the gene P53 is being made. And if we could use a car analogy, I would say that P53 is like the brake pedals in the car. It keeps things at bay. So when you have a mutation in P53, P53 no longer does that. So the brakes are now broken and they're off, and the car accelerates. The cancer cells grow quickly. And how do we detect this mutation? Well, we have very fancy testing where we can see if that section of chromosome 17 is lost, or there's very tiny mutations in the gene itself. These are pretty labor-intensive testing, but we have that capability now to test for it. If you do have a mutation in P53, it is considered high risk. And that means that when we start to talk about treatment, drugs that are in the category of chemotherapy are not likely to work the best. We are likely to shy away from chemotherapy and offer an alternative. And I will go into that detail much later on. The next category of gene mutations that we look for is something called heavy chain immunoglobulins. This represents a step in the CLL maturation pathway. So when a cancer cell matures and grows, it undergoes mutation of this gene. So mutated is actually a good thing. It suggests that this is a more mature looking cancer cell. When it's unmutated, it's less mature and it can be a little bit more aggressive. So when we look at the car analogy, unmutated immunoglobulins actually means you're pushing on the gas pedal. The car is moving quicker. Lastly, we're looking at chromosome changes, chromosome 11, chromosome 12. These, again, if you have mutations in these chromosomes, it's like pushing on the gas pedal. The car will go faster. The cancer cells will grow faster. However, chromosome 13, if you have an extra chromosome 13, so 3 of them rather than 2, is actually a good feature to have. So putting the genetic components together from most important in terms of aggressiveness to least important, we're looking at mutations in p53, and we're looking at unmutated IGHV, which I will call for short, or deletions 11 and 12. Later on, I will show you how this gets incorporated in our treatment decisions. So now we're going to talk about treatment options. The first step is to decide if it is chemotherapy that is best for you or immune therapy. And this is going to be based on a lot of those patient and disease factors that we previously talked about. So we're going to look at each entity, chemotherapy versus immune therapy, in detail. So with chemotherapy, it is generally given through the veins, so intravenous. Chemotherapy is often combined with an immune drug to work synergistically together. But because chemotherapy doesn't really have any specificity, it's just going to generally try to kill off the cancer cells, taking with it some normal cells. There are notable side effects of chemotherapy, and that discussion will happen between you and your cancer doctor. And we would really only offer chemotherapy if the cancer genetics was more favorable. So if you have a higher risk mutation that we talked about, like p53 or unmutated IGHV, we tend to shy away from chemotherapy and offer the alternative instead. When it comes to patient factors, when we're engaging with you in that conversation about chemotherapy, we are looking at talking to you about the side effects and benefit, conversing with you to see if that's in line with your goals of therapy, looking at your medical conditions, looking at your functionality to see if chemotherapy is still right for you. For some people, they do want time-limited treatment, and chemotherapy can offer that. It is really a course between 3 to 6 months, mostly 6 months, and then you're completed your treatment. And sometimes that is very desirable or a priority for a patient. And lastly, chemotherapy is really traditionally offered when it's your first time getting treatment. We don't use it as much when you relapse or when your diseases come back, but I have a slide about that later on as well. So some examples of chemotherapy would be drugs like fludarabine, bendamustine, cyclophosphamide, and they're given in the veins. There's also a pill form of a chemotherapy that's a much more gentler called chlorambucil, in which people can take at home. And like I said before, it is usually combined with an immune drug to act synergistically to kill the cancer cells. When we look at immune therapy, we're pretty much looking at pills that you can take at home, and it may or may not be combined with an intravenous immune drug. We typically offer these treatments for those with higher risk mutations that we talked about. But there are also side effects that need to be monitored and discussed and assessed with your cancer doctor. We always take into consideration patient preference, patient factors, and making sure this is in line with everyone's goals of treatment. The other thing notable about immune therapies is that there are limited fixed duration treatment, but many of the options are actually for continuous therapies, and we're going to talk about those. It is offered in first treatment or in relapse treatment. Now, when we talk about immune drugs, we're talking about non-chemotherapies, and they work by targeting a specific gene that causes the cancer growth. There are two classes. One is called Bruton tyrosine kinase, BTK, inhibitor, and the other one's called BCL2 inhibitor. So BTK inhibitor works at a gene called BTK, and BTK works after the cancer cell is activated to cause more cell growth. So drugs like ibrutinib or acalabrutinib that I've highlighted here will stop that BTK from working and therefore causes the cells to die. These are pills you take once a day or twice a day, and they're taken continuously, which means they take it until you develop a side effect that requires you to come off of it, or until your disease no longer responds. But there are lots of monitoring to be done while you're on this drug, and I particularly highlighted some cardiac or heart side effects that needs to be discussed with your oncologist. Next class is the BCL2 inhibitor, and that's a drug called Venetoclax. So BCL2 is another cancer-driving gene. Venetoclax comes in and kills and stops BCL2 from working, and therefore kills the cancer cells that way. On its own, it is a pill that you take once a day continuously. But we can combine it with obinutuzumab or rituximab that we've talked about before, and you can get a limited duration of 1 or 2 years. There is something unique about Venetoclax in that it kills the cancer cells really quickly, to the point that if it kills too quickly, the chemicals that's released from that cancer cell could damage the kidneys. So it needs to be given at a low dose and escalated up to maximum dose over a 5-week period. And during that 5-week period, blood work must be done to make sure that the kidneys are functioning well. So there are going to be many options to choose from. And again, it's going to be that discussion that you have with your cancer doctors to see what is the right drug for you. Well, how well do these therapies work? If we have the right match between the disease genetics and what the patient would like, and we match it well, the response can be very good. For instance, there are some disease conditions where chemotherapy drugs can result in a disease-free state even after 15 years, requiring no other therapies. So that is excellent. When someone's taking an immune drug, one recent study shows that at 7 years, there's an 80% chance of being alive at that 7 years. So also very good. The introduction or the use of these immune therapies has revolutionized the treatment of CLL with those P53 mutations, which are high-risk mutations. Despite that, though, there still remains a challenge in how to improve the outcome of these patients. So to put it together, I have shown you a very simple algorithm here of how we would think about which treatment to offer based on disease genetics alone. So this is for someone who is requiring a first-time treatment. We would first look to see if there's a P53 mutation. If there is, we would offer immune therapy and less likely chemotherapy. Then we look at the immunoglobulin mutation status. If it's mutated, we can offer chemotherapy and discuss that with the patient. But if they're not suited for chemotherapy, then we would offer immune therapy. On the other hand, if someone is unmutated IGHV, we would prefer to offer immune therapy, but some chemotherapies can be discussed here as well. In someone who has relapsed disease, we typically favor immune therapies over chemotherapy with a few caveats in there. The immune therapies can be used sequentially. So you can start with the BTK inhibitor and then go to BCL2 inhibitor or vice versa. So there's opportunities to treat at every relapse. Stem cell transplant, I get that question a lot. We only really use it if someone's multiply relapsed and if they're eligible, as stem cell transplant does carry with it high risk of the transplant itself. So it's not a gentle therapy. So we're very selective as to the type of patients that we would refer to the transplant doctors. CAR-Ts are very exciting or very new at this time, but it is only in clinical trials for CLL and not yet ready for enrollment. So in the next section, I am going to talk about what's coming down the pipeline in the next few years. It can get very overwhelming and complex, so it's really intended for those who have a keen interest in this area. So what do we want to achieve out of future treatments? There's 3 general principles that is being actively studied. One is, of the drugs that we do have, of the drugs that we know works, how can we improve it so that we maintain how well it works, but minimizing further the side effects? The second category is, how do we better improve the outcome in those with p53 mutations? And lastly, looking at whether deeper the remission is better. So how do we improve on the tolerability of the drugs that we already have? Well, these are some of the drugs that are currently being studied. BTK inhibitors, zanubrutinib, pirtobrutinib, are being currently enrolling into clinical trials, and I think they're going to come down the pipeline quite soon. There's a new BCL2 inhibitor that is in development, and there are clinical trials enrolling for CAR-T therapy. So how we move forward with a lot of these therapies is through clinical trial enrollment. If there is one that's open in your center, your cancer doctor will talk to you about that. So how do we improve on those with p53 mutations? One area that's being explored is to use BTK inhibitors along or together with the BCL2 inhibitor at the same time at first treatment to get the best response as possible. So lastly is deeper remission, the better. So what do we mean by that? This is an entity called minimal residual disease. So we have a way to detect CLL cells in the blood or the bone marrow at the end of treatment. If someone is undetectable, so which means to the best that our technology can do, we cannot find any CLL cells left over at the end of treatment, these patients seem to benefit from a longer duration of disease-free state before their disease comes back. So it makes us question, is getting undetectable minimal residual disease at first treatment the goal of our therapy? So this is being very actively studied. It is not ready for prime time, but I suspect in the next few years, this is starting to come more real, to be a real issue in the clinic. So I hope through today, you have an appreciation of the greater understanding we have of the biology of CLL and SLL. And through our understanding and our studies, we are rapidly developing new and better therapies. And this all translates to patients living better and longer. I would just like to thank you for taking the time to spend with me today. And I would like to thank all the patients and their families for their countless hours of dedication. Thank you very much.
Thank you, Dr. Yang, for your excellent presentation. We appreciate your thorough review of CLL and SLL, detailing diagnosis, prognosis, and treatment options that are available to Canadians. I would now like to direct our audience members to attend the live Q&A breakout session to have your questions answered by Dr. Yang. Thank you.